The autonomic nervous system can exert control over the heart's rhythm as well as its impulse conduction, and it does so via cardiac nerves. We can start with our parasympathetic nervous system, which is really ruled by the vagus nerve. This is primarily acting at the SA and AV nodes. It's really only minimally innervated to the atrial portion of the heart, not so much the ventricles. When it is stimulated, it's going to release acetylcholine at the vagus nerve endings, and acetylcholine acts to increase permeability of the membrane to potassium ions, which increases membrane negativity. It's making it more hyperpolarized, making the tissue less excitable. This will decrease the rate of the rhythm of the SA node. It also decreases the excitability of the AV junction, therefore slowing the transmission of an action potential to the ventricles. And overall, this gives you a slower heart rate. This is saying everything else all the things I already said on the previous slide, just in a different way. So again, parasympathetic fibers travel via the vagus nerve, cranial nerve 10, the preganglionic fibers synapse on ganglia, inside walls within the heart, and then the postganglionic fibers release acetylcholine, which binds our M2 muscarinic receptors. We see negative chronotropy here by the acetylcholine will increase potassium permeability, and that will then hyperpolarize our SA node, making it take longer to reach threshold, decreasing heart rate, causing bradycardia. Now, if you had really extreme parasympathetic stimulation, that could transiently stop the heart, and that is called vagal syncope. At the AV node, you'll see that conduction can also be slowed. This would prolong the PR interval on EKG. You could see an AV block if the vagal tone was too aggressive. And it can also affect contractility, which is called negative ionotropy, but this is minimal. Again, the vagus nerve is not really innervating the ventricles too much because they're primarily innervating the atria. There's some slight decrease to contractility. At resting state of our body, the parasympathetic tone is dominant and it keeps our heart rate resting at around 70 beats per minute instead of the SA node's natural rate, which would be around 100 beats per minute. The sympathetic nerves are distributed to parts of the heart, both the atria and the ventricles, with a stronger showing in the ventricular muscle. Norepinephrine is the neurotransmitter of choice released at the nerve endings, and this stimulates beta 1 adrenergic receptors. The stimulation will increase the cardiac impulse, increase the rate of discharge, increase the heart rate, and also will increase the force of contraction of all muscles, but specifically ventricles. Our sympathetic fibers come from the thoracic spinal cord between T1 and T5 via the cardiac nerves. Postganglionic fibers release norepinephrine that bind beta 1 adrenergic receptors. And also, they can be activated by circulating epinephrine or adrenaline that's released from the adrenal medulla. The positive chronotropy comes from norepinephrine increasing sodium and calcium permeability, the funny channels, and then resting membrane potential from our action potential will rise more quickly to threshold, which gives us a faster heart rate or even tachycardia. It will speed the conduction through the AV node, so it can shorten the PR interval on EKG, and then it can cause positive ionotropy by increasing intracellular cyclic AMP via the GS protein, which activates PKA. PKA will phosphorylate our L-type calcium channels, which leads to more calcium influx during that plateau phase. The greater the calcium release from the sarcoplasmic reticulum means a stronger, faster contraction, and it also will allow for the speed of relaxation to occur quicker as well. Clinically, this is where we can tie in different medications, although this is not a pharmaceutical exam, so you have to keep that in mind. We measure conduction using EKG, which we will look at next.